Okay, let's start with pneumonia, community-acquired pneumonia. Let's put our knowledge to good use and try to come up with a good regimen of antibiotics to pick and to justify during rounds to our attending and to the medical team. So with community-acquired pneumonia, I think of pneumonia in a non-immunocompromised patient, in a patient that does not have chronic lung disease and doesn't have any contacts or frequent contacts with the healthcare system. Okay, this is not a patient coming from a nursing home or has spent the last 2 weeks in a hospital. It's a patient coming out from the community, young and healthy, and has a pneumonia now. Okay? So this is our triangle of truth again. We have gram-positive, gram-negatives, as well as anaerobes and atypicals. What do we need to think about in pneumonia? Let's start with gram-positives. Strep pneumo. Okay, it's the most common thing. Pneumococcal pneumonia. For gram-negatives, H influenza, right, is a big offender and should always be covered. What about troublemakers? Gram-positive. Not really. A MRSA pneumonia is not something that we commonly see in community-acquired pneumonia. MRSA pneumonia would be something seen in hospital-acquired pneumonia or HCAP. What about gram-negative troublemakers, like Pseudomonas? Also not seen in community-acquired pneumonia. Anaerobes? Not really. Anaerobes are something that is seen in hospital-acquired pneumonia with aspiration of GI bugs. One exception are mainly alcoholics. Okay, alcoholics sometimes aspirate and get gram-negative or anaerobic pneumonia. What about atypicals? Yes, atypicals are very important and should not be forgotten. Okay, classic bacterium is Mycoplasma, Chlamydia, and Legionella. Okay, this is your walking pneumonia. Doesn't have a clear infiltrate, no clear consolidation, but rather an interstitial infiltrate. All right, that's where you see your atypical pneumonia. All right, so how do we pick antibiotics for those bacteria? First, we need to cover for gram-positive and strep pneumo. So we could do something like Augmentin or Unison. We need certainly to add some gram-negative coverage to it too. Ceftriaxone is a good choice. Other cephalosporins would probably work as well. And then, importantly, we cannot forget about our atypicals. Okay? So here comes in your erythromycin, clarithromycin, or even doxy. Okay? One more thing before we start building our antibiotic regimens are your fluoroquinolones, Cipro, Moxi, and levofloxacin. What do they cover against? First, strep pneumo. They do. About H influenza, they do as well. And lastly, for atypical, they cover for atypicals too. So they're a great choice if you want to pick one single antibiotic that covers against all those bacteria. Okay, so now we know our bacteria. We know our antibiotics that we can choose. Let's build upon this knowledge and come up with a good antibiotic regimen, and let's justify it. Okay? So first choice, Augmentin or Unison plus erythromycin or doxycycline. Great choice. Augmentin and Unison are going to cover for gram-positive, strep pneumo. They're going to cover for gram-negative, H. influenzae. And they're going to cover for your Mycoplasma, Chlamydia, and Legionella if you add erythromycin or doxy. Okay? Augmentin and Unison alone do not cover for those atypical bacteria. Next choice would be similarly ceftriaxone plus, again, erythromycin and doxycycline. Same idea, going to cover for gram-positive, gram-negative, but you do not forget about the atypicals. Last choice would be Cipro, Moxi, or Levo. So pick a fluoroquinolone. And the beauty is, again, you cover against all three at the same time with one single antibiotic, gram-positive, gram-negative, and your atypicals here. Okay? So those are your three choices. And if an attending asks you why you pick those, you can justify it. Okay, next we're going to talk about HCAP, hospital-acquired pneumonia. Okay, situation is a different one now. There's a patient with chronic lung disease, in and out of the hospital, just comes from a nursing home. Okay, has chronic lung disease. So all the risk factor for a lot of those resistant bacteria that would not be covered with a regimen that you chose for community-acquired pneumonia. Okay, let's go through it. Here's our antibiotic triangle. Let's go with gram-positives first. Gram-positives, you're going to have against strep pneumo. Okay, just similar to your cap, you can't forget about strep pneumo. For gram-negatives, you continue to have H. influenzae, but you also have other bacteria, okay, E. coli and Klebsiella. Other gram-negatives play a role now. For gram-positives, you have to think about MRSA now, okay? Your troublemaker is definitely in your spectrum of bacteria to expect in the lungs. For gram-negatives, also troublemaker Pseudomonas. Those are the two big things in HCAP, MRSA and Pseudomonas. Always need to think about those two, all right? What about anaerobes? Absolutely. Patients aspirate all the time in the hospital and in nursing home when they're sick, frail, or old. Okay, so you need to think about aspiration pneumonia and anaerobes. Atypicals, less so. So how would you cover for those things? First, for gram-positives and MRSA, your standard go-to is vancomycin. And that's what's normally in the antibiotic regimen. What about your gram-negatives and Pseudomonas? Classically, again, 3 options that we have: Ceftaz, Socin, or really, really broad, mostly not needed, is meropenem. Lastly, for your anaerobic flora, okay, you can use Clinda, you can use metronidazole or Unicin, or if you use Socin, Socin covers for anaerobes as well, as does meropenem. But importantly, Ceftaz does not. Okay, it does not cover for anaerobes. Okay, and then lastly, our fluoroquinolones. All right, they work against gram-positives, but not MRSA. They work against gram-negatives and Pseudomonas, at least if you use Levo or Cipro. Moxi is not effective against Pseudomonas. Their big issue is the oral aspiration flora. Okay, the anaerobes, they do not work against anaerobes. Okay, so again, based on that knowledge, let's build our antibiotic regimens and let's justify them. First option, your standard one. The ED loves it, everybody loves it, Vanc and Socin. Okay, why Vanc and Socin? First, gram-positives and MRSA are covered with Vanc. Gram-negatives, Pseudomonas, covered with Socin. Anaerobes, covered with Socin. So very good regimen if you have it. So Yale New Haven Hospital currently has a shortage of Socin. So we don't have enough Socin. Though the ED can give it for one time, but then if the patient arrives on medicine, there's no Socin left and we have to come up with something different. What would be a different antibiotic regimen? What about vancomycin, Ceftaz, and Flagyl? Vancomycin, again, covers against MRSA and gram-positives. Ceftaz covers against gram-negatives. It covers against Pseudomonas, but it does not cover against anaerobes. Okay, so that's why we need to add metronidazole or Flagyl to it. Okay. Lastly, you can pick vancomycin, levofloxacin, and Flagyl. Similar to Ceftaz, Levo is going to cover for gram-negatives. It's going to cover for Pseudomonas, but not going to cover for anaerobes.